graciously endowed a lectureship in memory of his name and to continue his legacy of teaching. And so I'm very honored today. We have two speakers for you today. Our first is Dr. Lincoln Denise, who'll be speaking on pediatric metabolic white matter disease. And our second is our research student, Spencer Chris, who'll be speaking to us on a short presentation on a new radiographic finding associated with abusive head trauma. We first start with Dr. Denise. Dr. Denise did his radiology and medical school training in Goa, India. He came to the University of Cincinnati where he did his pediatric, we did his neuroradiology fellowship, and then also did his pediatric fellowship work at Cincinnati Children's Hospital. And he came and joined our faculty in 2011. So I'm honored here to introduce Dr. Denise speaking on pediatric metabolic white matter disease. Dr. Denise.
Good morning. Metabolic brain disease is a vast topic. I'll try and keep it simple and short and point to important features of the disease as I go along. Listed are objectives. I'll start with a brief recap of white matter anatomy and function, normal myelination, and then talk about each of the conditions, a condition based on location and type of impairment of myelin. White matter is located in the central and subcortical regions of the cerebrum and cerebellum. It contains nerve fibers, interstitial tissue, supporting tissue, and vessels, and forms white matter tracts that connect adjacent gyri through association fibers, the hemispheres across the midline through commissural fibers, and the cortex to the brain stem and spinal cord through projection fibers. At the cellular level, white matter is composed of neurons, astrocytes, oligodendrocytes, microglial, and ependymal cells. Neuron, as we all know, conducts sensory, motor, and proprioceptive impulses throughout the central nervous system. The picture here is an example or illustration of a neuron. The axon is located centrally and conducts signals in the form of action potentials from the cell body to the axon terminal, where it then synapses with dendrite of another neuron, and that's how impulses are propagated. Myelin sheath wraps around the axon and is nothing but myelin that is laid down in concentric layers of plasma membrane. Myelin is composed of lipids and proteins. Oligodendrocytes myelinate axons in the brain and spinal cord. The diagram here is an illustration of an oligodendrocyte, which can contain up to 15 arm-like processes, allowing them to myelinate multiple axons by wrapping or spiraling around them. Myelin sheath insulates axons and increases velocity of action potential through a process called saltatory conduction. Saltatory basically means a leap or a jump. So action potential, which is generated at the node of Ranvier, jumps across from one node to the other, and myelinated axon facilitates this jump, increasing the speed of impulse conduction. Myelination begins as early as the 20th week of gestation and is mostly complete by the first 2 years of life. The table here shows myelination of white matter structures in utero and through the first 2 years of life. As you can see, the median longitudinal fasciculus is the first white matter structure that shows myelination as early as the 25th week of gestation. Myelination then proceeds in the caudate to cephalid, dorsal to ventral, and central to peripheral direction. These are MR images of a 6-week-old child showing myelination. T1 weighted images are on top, T2 images below. So on T1 weighted images, myelinated white matter appears as bright signal and appears as dark signal on T2 weighted images. T1 weighted images are used to look for early signs of myelination in the first 6 months of life because they are more sensitive to the lipid content of myelin. So in a 6-week-old child, the middle cerebellar peduncle, the posterior limb of the internal capsule, and the periventricular white matter seen here as bright signal on T1 weighted image and dark signal on T2 weighted image should normally be myelinated. These are T2 weighted images in a 2-year-old child showing near complete myelination of white matter, seen as dark signal in the cerebral white matter, in the genu and splenium of the corpus callosum, as well as the anterior limb, genu, and posterior limb of the internal capsule. These disorders are classified as leukodystrophies when they involve white matter only, polydystrophies when they involve gray matter only, and pandystrophies when they involve white and gray matter. Today's discussion will be on leukodystrophies. These diseases impair myelin by processes such as hypomyelination, which is decreased myelination of white matter, dysmyelination, which is breakdown of abnormally formed myelin, and demyelination, which is breakdown of normally formed myelin. The image on the top on the left is an example of leukodystrophy showing abnormal bright signal in the white matter diffusely. Image to the right is an example of polydystrophy where white matter myelination is normal, seen here as dark signal, but there is abnormal involvement of deep gray structures seen as bright signal in the posterior putamen, as well as swelling, edema, and abnormal signal involving the cortex. Images below are examples of leukodystrophy, polydystrophy, and the two images in the center are examples of involvement of white and gray matter. This disease presents with pyramidal signs such as spasticity, weakness, hyperreflexia, extrapyramidal signs such as difficulty initiating movement, chorioathetosis, dystonia, cerebral signs such as hypotonia and ataxia. And besides this, they also present with seizures, cognitive and behavioral issues, movement disorders, developmental delay, and focal neurological deficits. There are various ways these disorders are classified. This table here is a classification based on the cells that are involved. This is a classification based on the cell organisms within the cell that are involved. And this is more of an imaging classification based on involvement of the periventricular white matter or the subcortical white matter, or when the disease process involves hypomyelination. These conditions listed under periventricular and subcortical begin in these locations initially, but then eventually as the disease advances, they involve the deep white matter as well. Listed are periventricular leukodystrophies. So these disorders are caused due to gene mutations, which cause enzyme deficiencies or protein abnormalities, and these are listed for periventricular leukodystrophies. Metachromatic leukodystrophy is the most common metabolic white matter disorder. Occurs due to deficiency of aryl sulfatase A. So enzyme deficiency causes failure of reutilization of normally broken down myelin in the central and peripheral nervous system. The patients with the late infantile form of this disorder present with great gait abnormality, strabismus, spasticity, speech, and intellectual impairment. On imaging, there is decreased density in the white matter on CT. Characteristic feature on MRI is the tigroid pattern with stripes of dark and bright signal representing spared and affected myelin. After contrast administration, cranial nerves and cauda equina demonstrate contrast enhancement. The T2 image here demonstrates abnormal bright signal in the periventricular and deep white matter. There is sparing of the subcortical white matter. Signal abnormality in the peritrigonal white matter demonstrates the tigroid pattern with dark stripes representing spared myelin. Image on the left is an example is a diffusion radial sequence showing restricted diffusion seen as bright signal in the peritrigonal white matter. There is also some restricted diffusion in the genu and the frontal white matter as well. Image in the center and to the right are post-contrast T1 weighted images showing abnormal enhancement of the oculomotor nerve in the brain and cauda equina in the lumbar spine. Enzyme deficiency in Krabbe's disease results in accumulation of galactosyl sphingosine, which is directly toxic to neurons, oligodendrocytes, and Schwann cells. Characteristic feature on CT is increased density in deep gray structures, as seen on the CT image on top. There is increased density in the thalami with corresponding bright signal in the similar location on the T1 weighted image below. On MRI, there is abnormal signal involving the dentate nucleus, corticospinal tract in the posterior limb of the internal capsule, and the white matter. And like metachromatic leukodystrophy, cranial nerves and cauda equina demonstrate enhancement. Image on the top on the left demonstrates abnormal bright signal in the dentate nucleus. This image in the center shows involvement of the corticospinal tracts in the posterior limb of the internal capsule. Image on the right shows involvement of the corona radiata. Image below on the left shows involvement of the corticospinal tract in the pons. And this image in the center and to the right are examples of advanced Krabbe's disease showing abnormal bright signal in the periventricular white matter and deep white matter, as well as dilatation of the sulci and ventricles from volume loss. Adrenal leukodystrophy occurs due to mutation of the ABCD1 gene, which codes for paroxysmal membrane protein. So gene mutation causes secondary failure of oligodendrocytes, and that causes decreased myelination. There are two types. The childhood form is adrenal leukodystrophy, which involves the brain only. The adult form is adrenomyeloneuropathy, which involves the brain and the spinal cord. Adrenal insufficiency in the childhood form either precedes or follows the onset of neurological signs and symptoms. On imaging, there are two patterns. More common is the posterior involvement, as shown on the CT image here. There is low density in the splenium of the corpus callosum, the peritrigonal white matter, and the thalami. After contrast administration, the inflammatory edge of the lesion demonstrates enhancement. Image on the top on the left is an example of the posterior pattern showing abnormal bright signal in the periventricular and deep white matter. The most posterior aspect of the posterior limb of the internal capsule, the thalami, splenium of the corpus callosum, also seen on this sagittal flare image, and the axial T2 image. Image on the top on the right is an example of the atypical anterior pattern showing abnormal signal in the genu of the corpus callosum and the frontal white matter. Images below are examples of advanced adrenal leukodystrophy showing involvement of the corticospinal and corticopontine tracts in the pons, middle cerebellar peduncle, the genu of the corpus callosum, and this kernel T2 image here shows signal abnormality extending down from the internal capsule into the tegmental tracts within the pons. Image here is a post-contrast T1 weighted image showing enhancement of the inflammatory edge of the lesion in the genu and splenium of the corpus callosum. Patients with leukoencephalopathy with vanishing white matter present with ataxia, spasticity, optic atrophy, and seizures. And the symptoms are usually precipitated by trauma, infection, and fright. On imaging, as seen on this T1 weighted image on top, there's abnormal dark signal in the white matter with corresponding bright signal on the T2 weighted image below. This disease progresses to complete white matter volume loss. As seen on these flare images, there is near complete loss of white matter with sparing of some white matter in the frontal region, and there is ventricular dilatation from volume loss. Gene mutation in giant axonal neuropathy results in accumulation of ovoid aggregates in different cell types. On imaging, there is involvement of the cerebral and cerebellar white matter. Characteristic feature of this condition is abnormal signal and enhancement of the corticospinal tracts. T2 image on top demonstrates abnormal bright signal in the white matter There is selective involvement of the posterior limb of the internal capsule. Kernel flare image here shows abnormal bright signal in the cerebral and cerebral white matter. Enzyme deficiency in phenylketonuria results in accumulation of phenyl compounds that are toxic to the developing brain. Clinical clue to this disorder is musty odor of urine, skin, and hair. And characteristic feature on MR spectroscopy is the phenylalanine peak. On imaging, as seen on this flare image on top, there is abnormal bright signal in the frontal and parietal white matter, which has a flame-like appearance. There is corresponding restricted diffusion seen as this dark signal in similar locations on this ATC map below. Enzyme deficiency in maple syrup urine disease results in accumulation of leucine, isoleucine, and valine. This is one of the only metabolic white matter disorder where ultrasound is useful because patients present in the early neonatal period. On ultrasound, there is increased echotaxia in the periventricular white matter, basal ganglia, and thalamus. And on imaging, there's involvement of early myelinating structures, as seen on this T2 image on top. There is abnormal bright signal in the brainstem, in the cerebral white matter. T2 image below shows abnormal involvement of the posterior limb of the internal capsule and the optic radiation. Images on top are ADC maps showing restricted diffusion seen as dark signal in the brainstem, cerebral white matter, posterior limb of the internal capsule, optic radiation, and the peri-Rolandic white matter. Image below on the left is a flare image showing abnormal bright signal in the brainstem and the cerebral white matter, with corresponding bright signal representing restricted diffusion on this image on the right. Flare image in the center shows abnormal involvement of the genio of the corpus callosum and the frontal white matter, as well as the basal ganglia, the white matter between putamen and globus pallidus. Hyperhomosystemia occurs due to 3 enzyme deficiencies. The classic form is due to deficiency of cystathionine beta synthetase. Biochemical alterations in this disorder result in internal irregularity and fibrosis, causing arteriosclerosis, arterial thromboembolism, venous thrombosis, and arterial dissections. And as a result, patients present with multiple small cerebral infarcts. Other feature of this condition is dislocation of the lens. T2 image on the right shows abnormal bright signal involving the white matter with corresponding dark signal on this T1 weighted image on the left. There is some sparing of myelination in the internal capsule and optic radiation. Patients with Loeys syndrome present with a clinical triad of cataracts, mental retardation, and renal dysfunction. On MRI, MR imaging demonstrates dilated perivascular spaces and multiple small cysts in the white matter. The CT image here demonstrates bilateral cataracts. T2 image on the left shows dilated perivascular spaces and some bright signal in the white matter. Image in the center and on the right demonstrates multiple small cysts in the white matter. Mycolipodicis type 4 is commonly seen in the Ashkenazi Jewish population. So gene mutation causes accumulation of lipids and proteins within lysosomes. These patients present with visual impairment because of corneal clouding and retinal degeneration. And on imaging, as seen on the sagittal T1 weighted image on top, there is hypoplasia of the corpus callosum. Kernel T2 image below shows abnormal bright signal in the white matter, as well as cerebral and cerebellar volume loss seen as dilatation of the sulci and cerebellofolia. Jogren-Larsen syndrome occurs due to deficiency of the enzyme fatty aldehyde dehydrogenase. This enzyme normally oxidizes fatty aldehyde to fatty acids. So enzyme deficiency results in accumulation of long-chain fatty alcohols. On MR spectroscopy, the feature is this peak labeled SL, which stands for the syndrome, which is seen after the normal and acetyl aspartate peak. Flare image on top shows signal abnormality diffusely involving the cerebral white matter. The table here summarizes MR spectroscopy findings in each of the periventricular leukodystrophies. So there is the phenylalanine peak in patients with phenylketonuria, long-chain fatty alcohol peak in patients with Sjogren-Larsen syndrome, and most of the other disorders on the in the columns on the left show a decrease in N-acetyl aspartate, increased choline, and increased myoinositol, and this occurs due to neuronal damage and demyelination. This is the next set of disorders involving the subcortical white matter. The table here lists gene mutation causing enzyme deficiencies in each of the subcortical leukodystrophies. Megalencephalic leukoencephalopathy and with subcortical cyst and cystic leukoencephalopathy are grouped because of similarities and differences between the two. Patients with megalencephalic leukoencephalopathy are macrocephalic. Those with cystic leukoencephalopathy are microcephalic. On imaging, both the conditions show subcortical cyst, typically in the temporal lobes. Patients with megalencephalic leukoencephalopathy should be differentiated from Canavan's disease because of macrocephaly, and CMV infection because of the subcortical cyst. Patients with cystic leukoencephalopathy should be differentiated from CMV infection because of microcephaly and the subcortical cyst. These are examples of the two conditions. Flare image on the left shows subcortical cyst in the temporal lobe. There is abnormal bright signal involving the cerebral white matter. Coronal image here shows abnormal bright signal in the cerebral and cerebral white matter. Images on the right are examples of cystic leukoencephalopathy, sagittal T1 weighted image showing subcortical cyst in the temporal lobe, and this flare image here showing abnormal bright signal in the periventricular and deep white matter. Aicardi-Goutieres syndrome and Cockayne syndrome are grouped because of similarities on imaging. Both conditions demonstrate basal ganglia calcifications and cerebral atrophy. Patients with Cockayne syndrome present with photosensitivity, premature aging, and ocular abnormalities. These are examples of the two conditions. The CT images showing increased density, representing calcifications in the basal ganglia region, and also cerebral atrophy. T2 image here shows dilatation of the extraaxial CSF spaces, the sulci, and ventricles from volume loss. And calcification, basal ganglia calcification is seen as this dark signal in the basal ganglia region. Similarly, this flare image shows basal ganglia calcification seen as dark signal, bright signal in the cerebral white matter, and some cerebral volume loss. Enzyme deficiency in galactosemia results in decreased conversion of galactose to glucose. One of the treatments for this condition is dietary restriction of galactose. So if untreated, these patients present with liver disease, mental retardation, and epilepsy. The T2 image here shows diffuse blurring of gray-white differentiation from delayed myelination. This is the last set of disorders due to hypomyelination. Table here lists gene mutation causing enzyme deficiency in each of the hypomyelinating leukodystrophies. Gene mutation in Pelizaeus-Merzbacher disease results in accumulation of proteolipid protein, and this is toxic to the oligodendrocytes, resulting in decreased myelination. Patients with the classic form of this disorder present with nystagmus, motor delay, involuntary movement, and spasticity, and these patients are often confused or mistaken for cerebral palsy. On imaging, as seen on this T1 weighted image on top in a 2-month-old child, there is diffuse decreased myelination seen as dark signal in the white matter. T2 image below shows diffuse hypomyelination seen as bright signal in the white matter. These images show evolution of Pelizaeus-Merzbacher disease. Images on top in a 3-month-old child again show decreased myelination seen as dark signal on this T1 weighted image and bright signal on T2 weighted image. there is some myelination seen in the posterior limb of the internal capsule. Images below in the same patient at 9 months of age show no interval progression of myelination, with again dark signal on T1 weighted image and bright signal on the T2 weighted image. On this, 9 months later, the T1 weighted image shows regression of normally formed myelin at 3 months of age. Enzyme deficiency in hypomyelination with congenital cataracts decreases production of myelin, and the little myelin that is formed is subsequently broken down. As the name suggests, these patients present with cataracts and also motor delay, hyperreflexia, and cerebellar signs. T2 image here shows abnormal bright signal in the deep white matter. There is sparing of the periventricular and subcortical white matter. This image also shows bilateral cataracts. Sagittal T1 weighted image on the left shows abnormal dark signal in the deep white matter. There is sparing of the subcortical white matter seen as bright signal. Coronal image in the center shows abnormal bright signal in the cerebral white matter and cerebral white matter. There is sparing of the subcortical white matter. And this ADC map here shows increased diffusion seen as bright signal. Hypomyelination with atrophy of the basal ganglia and cerebellum, POL3 leukodystrophies, and celiac acid storage disease are grouped because of similarities between the three conditions. The pathology in all three of them is hypomyelination. And on imaging, the corpus callosum is thin, and there is cerebellar atrophy. Patients with POL3 leukodystrophies present with a clinical triad of motor abnormalities, abnormal dentition, and hypogonadism. The adult form of celiac acid storage disease is predominantly seen in the Finnish population. These are examples of the three conditions. Sagittal images on top showing thin corpus callosum and cerebellar atrophy, seen as prominence of the vermin fishes. Image below on the left shows basal ganglia atrophy. And all the three images show abnormal bright signal in the white matter from hypomyelination. Table here summarizes spectroscopy findings in each of the hypomyelinating leukodystrophies. Most of them showing increased myoinositol and increased choline, and there's unusual increased N-acetyl aspartate in patients with Pallises-Marsbacher and celiac acid storage disease. A quick word about Canavan's disease, because it was mentioned while differentiating this condition from megalencephalic leukoencephalopathy. This is an example of a pan-dystrophy where there's involvement of white and gray matter and occurs due to deficiency of aspartoacylase, which results in accumulation of N-acetyl aspartate in the brain, some of which crosses the blood-brain barrier and is excreted in the urine. These patients are macrocephalic, and on MR spectroscopy, almost pathognomonic finding is this elevated N-acetyl aspartate peak. There's decreased choline. On imaging, there's involvement of the cerebral white matter, globus pallidus, and thalamus. T2 image on the left shows abnormal bright signal involving the globus pallidus. There is diffuse abnormal bright signal involving the cerebral white matter. There is corresponding restricted diffusion seen on this ADC map here as dark signal. Images on the right are examples of advanced Canavan's disease showing macrocephaly, abnormal bright signal involving the globus pallidus and thalamus, and diffusely involving the cerebral white matter. There is also ventricular dilatation from volume loss. So to summarize, metachromatic leukodystrophy is the most common metabolic white matter disorder. Diagnosis in this conditions is based on integration of clinical and genetic information together with imaging findings. Despite extensive investigation, 50% of these disorders remain undiagnosed. On imaging, typical findings are decreased density in the white matter on CT and bright signal in the white matter on T2 and flash sequences on MR. There are some conditions which show similarities in findings, but many of them show characteristic features or patterns. Patients with metachromatic leukodystrophy, Krabbe's disease, and adrenal leukodystrophy demonstrate contrast enhancement. Calcifications are seen in patients with Aicardi-Goutieres syndrome and Cockayne syndrome. Patients with megalencephalic leukoencephalopathy and cystic leukoencephalopathy demonstrate subcortical cysts, typically in the temporal lobes. Patients with hyperhomosystemia present with cerebral infarcts. Cataracts are seen in patients with hypomyelination with congenital cataracts, Loeys, and Cockayne syndrome. And on MR spectroscopy, there's the phenylalanine peak in patients with phenylketonuria, long chain fatty alcohol peak in patients with Jogren-Larsen syndrome. And most of the other conditions show decreased N-acetyl aspartate, increased choline, and increased myo-inositol from neuronal degeneration and demyelination. Patients with Mycolipodicis Type 4 is commonly seen in the Ashkenazi Jewish population, and sialic acid storage disease is predominant in the Finnish population. Thank you. Questions, comments? Okay, please stand by for Spencer's short presentation.
Good morning, everybody. My name is Spencer Chris. I'm a research student at Norton Children's Hospital working in the Department of Radiology. And today I'll be presenting to you all our research work titled Pediatric Skull Fractures, Contacting Sutures, Significance in Abusive Head Trauma. So previous work in abusive skull fractures and head trauma has been performed primarily in the Hobbs and Meservey papers, outlining characteristics that are associated with abusive skull fractures. Those include diastasis, fracture widening, depression of the fracture, comminution or the formation of an island of bone, multiple terminal ends, bilateral skull fractures, and in terms of cranial suture involvement, these papers documented that when fracture lines crossed or widened cranial sutures, that was associated with abusive injury. So I'm going to run through just some of these characteristics with images associated with them here in the next couple slides. In this image here on the left, we can see a diastatic fracture right here. You can see the fracture line widening, and the Hobbs and Meservey papers have concluded that this characteristic is associated with abusive injury. In these two images here, we can see depressed fractures. On the left, in this CT image, we can see the skull fracture causing the bone to cave in. And on the right here, we can see on this head 3D CT a ping pong type fracture. Both of these are depressed fractures and both are associated with abusive injury. In this head CT up here on the right, we can see comminution or the formation of an island of bone. We see this free floating piece of bone separated from the rest of the skull. On the left here, we see a fracture with multiple terminal ends, and both of these are associated with abusive injury. In these images here on the left, we can see this fracture line crossing the lambdoid suture. And then up here on the right, we can also see a fracture crossing the lambdoid suture and the subsequent widening here of the lambdoid, as well as the widening of the temporal suture. Hobbs and Meservey papers document that fracture lines crossing and widening these sutures was associated with abusive injury. So the purpose of our study and our work was to try and identify a new skull fracture characteristic that is associated with abusive injury. We primarily looked at fracture lines, extension and propagation across the skull, and contact with cranial sutures, and whether there was relevance there in terms of the difference between abusive and accidental trauma. So our methods, we primarily utilized 3D head CT images, which allowed us to get lateral, frontal, and vertex views of the skull. From these images, we were able to clearly define and see the skull fracture as well as the sutures. As you can see here, clearly the lambdoid, temporal, coronal, and sagittal sutures. It made it very easy to diagnose and recognize where skull fractures were going across the skull, as well as whether or not they were contacting cranial sutures. We performed a retrospective radiographic review of abusive and accidental skull fractures in children who received head CT imaging for head trauma from 2012 to 2019 at Norton Children's Hospital. Accidental versus abusive etiology was determined from the electronic medical record. We did not include any indeterminate or postmortem cases in our study. In our control group or our accidental group, we did not include any high impact or potentially high energy accidents, such as a motor vehicle accident. These kinds of accidents can cause serious, significant skull fractures, and there's no concern in these cases for abusive injury. Our inclusion criteria for our control group, we were looking for accidental cases such as household falls and drops by caretakers. The reasoning for this is these are the exact kinds of cases physicians are going to be evaluating and questioning or considering for abusive injury. So our results, we documented 47 children with abusive skull fractures and 47 children with accidental skull fractures. The majority of these patients that we looked at were under 6 months of age, and almost half of them were under 3 months of age. So we were primarily dealing with infants and very young children. We noted that the parietal bone was the most common fracture site in both abusive and accidental groups, which makes sense being the biggest bone in the skull. We also noted in our abusive cases that the most commonly contacted suture by a skull fracture was the lambdoid suture, which makes sense when we consider the commonality in abuse of posterior occipital trauma and things like shaken impact syndrome. In our accidental cases, we did not find a statistical difference in terms of which suture was contacted, likely more due to the random nature of these accidental cases and the variance in the traumatic impact site for the injury. When we looked at importance of skull fractures contacting just one cranial suture, we found that it was common in both our abusive and accidental cases for a fracture to propagate across the skull and reach one suture. However, when we changed this criteria to contact of 2 or more sutures, we found statistical significance. We noted that almost 70% of our abusive skull fractures touched 2 or more sutures, and almost 20% of those touched 3 or more sutures, while in our accidental group, we found that only 7% of accidental fractures touched 2 sutures, and none of them touched greater than 2 sutures. In these images here on the left, we can see an abusive fracture touching the coronal suture and going all the way and hitting the lambdoid here. And on the right, we can see an accidental fracture only touching the lambdoid suture. So the obvious question would be, why did we find this statistical disparity between accidental and abusive etiology in these cases? And the primary answer we found in the energy and the force of impact that comes behind accidental versus abusive trauma. In general, abusive fractures have much more and much higher force of impact, whether it be hit, throw, or slamming of the skull, that can cause increased fracture extension and propagation. In accidental household fractures, the typical force at work is gravity, which would bring less energy and force with it compared to an abusive scenario and cause less propagation across the skull. And this is primarily why we saw the abusive fractures could propagate across and touch 2 sutures, while in our accidental cases, there simply wasn't enough energy to drive the fracture across the skull to reach multiple sutures. In these images here on the left, we can see an abusive situation where this fracture is diastatic, has multiple terminal ends, and contacts the coronal suture here, the temporal suture here, and the lambdoid suture here. On the right, we can see an accidental fracture that only contacts the lambdoid suture. So just looking at these 2 images, you can see the difference in the force and energy behind the 2 etiologies, accidental and abuse. In these images here, both these fractures are relatively similar. There is slight diastasis, but it isn't clearly evident or distinguishable, and they both are in the parietal bone. But on the left here, we see contact with the sagittal suture, and then all the way across to touch the coronal suture. while on the right we only see contact with the sagittal suture. The left was an abusive case and the right was an accidental case, and the primary distinguishing characteristic between the two is the contact of sutures and how many the fracture reached. On the left here we see an abusive case with contact of the fracture here at the sagittal suture, going all the way across and reaching the temporal suture. On the right here we see an accidental case where the fracture contacts the coronal suture and propagates across the skull. However, it doesn't have enough force and energy behind it to propagate all the way across to reach the sagittal suture in this case. This new two-suture rule can essentially be applied in radiographic evaluations of potentially abusive cases. We recognize that no single imaging observation is going to be absolute, but this finding certainly presents a red flag for abusive injury. If a fracture has enough energy and force behind it to propagate across the skull and contact two or more cranial sutures, then there is serious concern for non-accidental trauma or abuse. Because of this finding, physicians can utilize the two-suture rule to initiate comprehensive abusive medical evaluation, including a skeletal survey can be initiated, and children can be protected and potentially removed from a harmful and abusive situation. Thank you all for listening, and hope you all have a wonderful day.
All right, are there any further questions for our presenters today?
Surface of contact in terms of what is being hit, I guess where the skull is hitting, or
They're saying carpeted versus non-carpeted, like
Oh,
the
for
surface
accidental.
they're hitting.
probably gravity is going to be the main force, so probably not huge impact. No.
If there are no further questions, that will conclude pediatric grand rounds. Thank you all for your attention. Have a great day.